Welcome to the Moulding Health Show. Our goal is to leverage the wisdom and experience of healthcare practitioners to set you on a path of self-discovery and healing. These insights, coupled with a multidisciplinary approach to each area of interest, should provide an invaluable resource to everyone looking for a better approach to health. In this episode, we speak to Lucas Breedt about foot management for people who have diabetes from a podiatrist perspective. Lucas Breedt, welcome to the show. We're really glad to have you on board. We've been looking forward to this for quite some time now because I think we don't often get to speak to a podiatrist. So we're very, very excited to have you on board. Welcome to the show.
Thank you very much, Oliver. It's great to be here. Always happy to chat about podiatry. I just don't think you've allotted enough time for us because if you ask any of my colleagues, once I get talking, hardly ever shut up. So just remember to give me a cue if I go overboard.
I actually love that you said that because, we've had quite a few practitioners on now and normally we book, normally 30 minutes and, it should be fine. And I remember a speech therapist, the first time we did this and she said, are you sure you have enough time? Because, speech therapists can talk a lot. And so I thought that's quite funny, but it's interesting that you say podiatrists do as well.
They do.
Okay. So the reason I'm quite excited about doing this is that I think, and this is more maybe my own personal experience, but I think probably podiatrists don't get as much credit as they deserve. And it's almost like you only speak to a podiatrist when something is wrong. And I'm hoping that we're going to kind of peel off the masks a little bit now and, talk about a much more proactive approach to this. And I think the topic that we're talking about is in particular foot management for diabetics, but hopefully we can spin this into something bigger. So maybe just to kick it off, tell us, a little bit about that area of interest. And in particular, do you see that quite a lot in your private practice?
Alrighty, so thank you. First of all, just to make people aware that we actually are celebrating Diabetes Month in November. It's an annual event. So thank you. I mean, this has been really well structured in terms of the timeline in which all this goes. So we are getting geared up for all things diabetes. Diabetics are possibly one of the most common patient profile that I see in my practice. Apart from sports patients, they probably make up around about 50% of my patient base. And it will range everything from a basic diabetic or foot assessment, basic not being 100% accurate, but from just an annual diabetic foot assessment to seeing them on a monthly basis for everything from general care to wound management. And you are quite right. These patients often only present towards or when they're in a very, very sad state or in a very severe state. And that's usually when you get the whole story of I've been to everyone, you are my last hope, that sort of things. And that's part of it is that podiatry in the past has definitely not marketed itself very well. We've never really pushed our profession the way it's currently being pushed, on the way we're seeing it being pushed now. And a big thing I think in that regard is social media has helped a lot. It's made it a lot easier for us to advertise our practices, made it a lot easier to generate awareness. From just my side in chatting with patients, TV shows where podiatrists are being mentioned and where podiatry is taking center stage has also helped a lot and has generated a lot of awareness. So yes, that has definitely been a problem in the past, but there is been a fundamental shift in the last 2 years with regards to the role of podiatrists and podiatrists starting to be regarded as the gatekeepers of the foot. And that's something we should have always done, we should have always pushed, but it's definitely something that's picked up momentum in the last 2 years.
It's actually so interesting. So I must say, we try to keep it personal as well. But, I remember, my mom's always struggled with these bunions on her feet. And I remember the first time we ever went to a podiatrist, and I can't even remember who referred us, but, she was so scared. And
Yes.
I just think it's almost like your hands and your feet are probably the things that you use the most often. Like during the
Yes.
day you're always busy with your hands. You're walking
Yes.
around everywhere, and it's so weird that like people like it's almost like as you said there's no awareness of this, and I think that's quite interesting for me as a person. And so I mean, from a diabetic point of view, is there regular things that people need to do from a from a management of the condition?
Okay. So as the most important thing that we always emphasize, and that any practitioner will always emphasize with a diabetic patient, is the importance of glycemic control. So keeping that sugar well controlled. Whether it is testing yourself regularly, taking your medication as you should be, making sure you cut out excessive sugars and get regular exercise. So that is always number one. Diabetes is a quite a predictable condition in the sense that complications always arise from the sugars from sugar spikes. So patients will often present with will find that their neuropathy gets worse when they have a sugar spike. Their circulation drastically reduces or gets particularly worse when during a sugar spike. So that is the most important thing, is making sure that you keep those sugar levels under control. Take your meds the way they've been prescribed to you at the correct times that they've been prescribed to you. Maintain a good diet. Have moderate exercise during the week. From a foot perspective, so if you have someone to help you, a partner, a spouse, children, have them check your feet every night. Check for things like blisters, cuts, strange objects that might be stuck in the foot. Anything that can cause or could create a portal of entry for infection and then ultimately ulcerations. If you have corns and calluses, have them seen to by a podiatrist would be my first choice. But there are some pedicurists or technicians, beauty therapists, somatologists out there that also do fantastic work. So making sure that you don't have a lot of callus buildup, because those lead to pressure points, which can also lead to decubitus ulcerations, are a nightmare to heal. Making sure you have adequate footwear. So in the case of a diabetic, have someone to help you fit your shoes. Diabetics, because they lose sensation later in the disease process, they'll often either start buying shoes that are way too small for them, or they'll start tying it way too tight, and that'll lead to other issues like pressure sores, like corn and callus formation. Same with nail cutting. Have someone help you. As you get older, your feet get further away from you. It gets harder to see your toes. So rather consult your podiatrist, chat to them about seeing them once every 6 to 8 weeks to help with the nail cutting, or see someone like a qualified or a trained technician to assist you with your nail cutting. And also, again, make sure that you don't have any cuts on your toes. Dry in between your toes very well. You don't want that macerated tissue that can lead to fungal infections, and again, lead to ulceration. So that's really important. From a basic foot hygiene perspective, it's all the things that we've always been taught how to do. Wash between your toes, dry between your toes, use a separate towel for your toes. If you need to, a little bit of foot powder isn't a bad idea if you do sweat a lot. Diabetics as well, because of changes in blood circulation to the foot, structures like your sweat glands get affected. So those patients might initially start sweating more, but then they might need to then use a bit of baby powder, or and then later in the disease process, they'll develop a very dry foot. So then making sure that they use a good moisturizing agent every day to prevent any cracks or hard skin. So basic things like that is what we would discuss with your patients. And of course, if it is on the foot, see a podiatrist first. That's usually my advice to those patients as well. But management, once every 6 to 8 weeks, visit a podiatrist, visit a qualified nail technician who can assist you with just basic management, so you don't get ingrown toenails or cuts or corns and calluses that can lead to cause bigger problems a lot later in the disease process.
Lucas, you said a very interesting thing there. Diabetics actually start to lose sensation in their feet, which is why you need the help of loved ones or professionals such as yourself to make sure that things like toenails and stuff are cut. And would the reason very simply be because ultimately they just actually don't feel their feet? So a diabetic could step on a thorn, not notice it, and that will eventually become an infected wound.
Yes, and that happens quite often, where a patient might step in a nail or in a thorn, they don't feel anything, and then over time they'll one day happen to look at their feet, and this is often the case where you'll hear, I just looked down and my foot was red and swollen, and then I asked my grandkids to look underneath there and they said there's a hole in there. So it can be something as basic as that. Summer months, now with December coming up, I usually have a patient that was either walking around the pool on a very hot summer day without shoes and burnt blisters on the soles of their feet. And they'll often come in early, mid, late January with severe ulcers, needing help. And it's just a point of they just didn't notice it. I mean, I have patients who regularly cut themselves, and if their kids don't say, "But why is there a blood trail on the floor leading to Grand's foot? What's going on? We need to see someone." So that often happens, and it is with one of the hallmarks of a diabetic foot is the neuropathic changes that happen with it. And again, it's usually associated with long-term diabetes, long-term uncontrolled diabetes, and that lead to that condition being as severe as that.
Wow, that's actually so insightful, hey. And again, I mean, so my mother-in-law has diabetes, and I mean, I don't know too much about it, but my wife's like extremely scared of it. I mean, she's not diabetic, but she's always been saying, you know, she's prone to be diabetic, so she's very conscious of those things. But I actually didn't know that. I mean, this is the first time I've heard, you know, of you mentioning that, you know, that they actually don't know that they've been hurt or stuff like that. You know, the one thing that's always interested me about, well, not interested, but more scared me about being diabetic is the fact that you can't, you know, it's like having a thyroid condition. It's like, how do you know you actually have it under control? I mean, I think they measure every day, as she does, but in between the day as well, there could be that fluctuation. So when you say unmanaged, is it like every day that they check and if they're within the, you know, the levels, they should be good, or is it more than that?
So the usual rule of thumb for diabetic patients is you want a sugar level, if you're doing a random blood glucose test, so that's the little test you do in the mornings and in the evenings and in between the day, you should be between 3.6 and 6.3. Alrighty, and in a lot of cases, we might even go to a 7, but that's pushing it a bit. So when we talk about uncontrolled diabetes, it would usually be these patients where if you do a random blood glucose test, they would be sitting at between 12 and 22 at any given moment. Also, we as part of diabetes management, once every 6 months or once a year, depending on your control and who your physician is, you will probably do what's called an Hba1c test. Now, this is one of the tests that we use to determine how well controlled the patient is, because it gives us an idea of what the patient's sugar levels have looked like over the last 3 months. And in that case, we usually want it below a 7%. So it gives you a percentage, and we usually want that under 7%. In an uncontrolled diabetic, you'd probably look at anything over 7%. And commonly, those patients I find will have either 10 or 12%. And they're the ones who have the severe complications. So in the case of a diabetic, the best way in which, as a diabetic, you can monitor yourself is with that random blood glucose test, and making sure that you're hanging around at a fasting level. You should be between that 3.6 and 6.3. So fasting means morning when you've woken up, before you've had breakfast or taken anything in, test your sugar, see where it's at. The idea would also be to test it just before lunchtime to check what your fluctuations were, and then about 4 hours after lunch, because that's usually when your insulin levels will dip again and your sugar levels will start spiking. And then just before bed to see what your sugar levels are like. So, and then fluctuations are okay. But you don't necessarily want it to be sitting at a 14 the entire day. That's telling us that something's wrong. Either you're not responding to medication, or in the case of a pre-diabetic, you're probably in the diabetic range by then.
So, I mean, it's quite complicated, eh? I mean, I was listening to the Apple event last week, and I was just hoping, the iPhone 7 comes up with anything close to like, real-time monitoring of heart rate and or blood pressure or like sugar. But I think that would be amazing, if we ever get to that stage, where you can actually have much more real time. Because I mean, lots of these, what you're mentioning is, it does require the person to be quite diligent, or have assistants around them that's quite diligent about taking these measurements. And for a fact, I know, like I'm not sure if my mother-in-law takes it all the time. I think she takes it randomly, but yes. I'm not sure if she does. It's like exactly what you just said now, which makes a lot of sense. It's it makes on a logical level, that is exactly what you should do. And there's a case for almost like having people coming and checking, proper assisted care almost. And it's something I think I'm taking out of this. But coming back to the foot management that you mentioned, I have to ask, so do you recommend that, again, you mentioned the sweat and stuff like that. So do you recommend that diabetes patients use more sandals or more closed shoes, or how does that work? Because I know even with closed shoes, closed shoes give you more support maybe for the feet. But do you have a recommendation or a preference one way or the other, or does it depend on each client?
I like individualizing my care, so I do take it as an individual level. As a general rule, we often don't want diabetics necessarily to be spending a lot of time barefoot or in something like a flip-flop. But because we live in South Africa, we have a relatively warm tropical climate. It's not always ideal or realistic to tell a patient every day, 60% of the day, you're spending it in a closed shoe. So usually what I would advise a diabetic patient, again, depending on their lifestyle, what to do. If it is someone and they say, look, I don't like closed shoes, and I have a lot of those patients that come in and say, I don't like wearing shoes. Then we need to find a middle ground. So then we'd often recommend an orthopedic sandal, which would need to be non-slip so that they don't fall and hurt themselves. It needs to secure to the foot very well with either a buckle, straps, Velcro, laces, and then it needs to give an adequate of medial arch support, as well as being relatively having a good balance of cushioning and stiffness to support the foot. If we look at a tacky or a closed shoe, I like tackies because they're usually comfortable for the patient. Patients can easily access them, and they're easy to give a guideline to. So again, you want something non-slip, the deep heel cup, laces securely, either laces or Velcro. I don't necessarily like the slip-ons because they very seldomly give you adequate support, and something that is a good balance of cushioning and stiffness. Why we say good balance of cushioning and stiffness is the perception is I need something soft. I need something that has a memory foam inlay that isn't going to push anything too hard. Not always a good thing. You don't want too soft, because too soft might lead to the foot reacting by becoming more rigid. And that's when you can develop painful syndromes and musculoskeletal pain. And often your very soft shoes lack the support your foot needs, or the stiffness in the sole your foot needs to give you adequate support. And that's where, again, consulting with a podiatrist when before buying shoes, or when you're looking at shoes before you're going to buy them, so that your foot can be assessed thoroughly, and then a proper recommendation for a shoe can be made. But general rule of thumb is it needs to sit securely to the foot, so flip-flops are totally out. If you want a sandal, ideally a sandal that's closed at the back or around the heel, to just give you a little bit more ankle support, and where that has straps that go around the top of the foot and possibly just around the metatarsal area, just before it gets to your toes, just to give you that of support. Often we sometimes we have samples in our practices, or we do sell orthopedic shoes. In most cases, they will have removable insoles, so that if we need to put an orthotic into the sandal, we can do that. We might recommend a tacky or a shoe where if we need to put an orthotic in, it will accommodate the orthotic well. But definitely, you want to stay away from flip-flops. Also, I know with the older ladies, there's a love of slippers. You want to try and stay away from slippers. And rather be in a tacky or no supportive shoe.
It's very interesting that you say we live in an environment where flip-flop seems to be the very common cause, or the other side of it is I don't like shoes.
Yes.
But I do understand that whole concept of, if you are somebody with diabetes, you need to find that common ground, because otherwise. And I think what happens with a lot of diabetics, they don't actually realize the end consequence. And the end consequence is you lose feeling in your feet. That means you could get some sort of infection or whatnot and lose a toe because you don't realize it, because you chose, I'm going to walk around in flip-flops and I'm not going to monitor my sugar.
Yes.
So do you find that that's very often the case, is people are just like, it's actually, I'll be okay. And suddenly you've got this worst case scenario of having to say to somebody, look, if we don't lose the toe, you're going to lose the foot.
Yeah. So one of the very scary things that I do find, it's very entrenched in South African culture, that I'm going to go to the doctor and the doctor's going to give me a tablet, and that tablet's going to magically fix me. But I'm still going to go to my braai. I'm still going to eat my 3 chops, 2 worshies, potato bake, broodjie, and a load of other starches, and the salad kind of just stays on the side because that's just decorative. So it is unfortunate. It is only when we get to a point where we need to start discussing things like, all right, if we don't get this wound closed within the next 8 weeks, we need to consider amputation. And that is a very difficult conversation to have. And that's usually when you have a lot of tears and waterworks and, you have to help me, we have to save this foot. But we're basically trying to save 40 years of neglect in 8 weeks. And that's very much what I have found from a South African perspective. It's a very entrenched in our society, that whole thing of, I'm going to go to the doctor, he's going to give me something, he's going to give me a little tablet, and the tablet's going to sort it out. And we with very little regard for lifestyle changes. It's very rare I will have a patient who will sit in front of me and say, I got diagnosed with diabetes, and since then I've been exercising, I've changed my diet, I've stopped drinking, I've quit smoking. Those are the rare cases. I often find with diabetics is the opposite being true. I've just found out I'm diabetic, so I'm going to live like there's no tomorrow, and I'm going to take my tablet because the tablet should work. The doctor said the tablet should help me. But we keep pushing the boundaries. It's only when there's a hole in the foot and we need to start talking about how we're going to cut this, where we're going to start amputating, that it becomes a reality. So it's probably one of the things that in diabetic education, not that we want to scare or traumatize the patient, but we really need to have very frank discussions with patients very early on in their disease, in the disease profile. And I think we often do baby our patients a little bit too much. where we should actually be having very, very stern conversations right at the start with them of what can happen to your foot. You stand to lose a limb, and every amputation that you have halves your life expectancy. So, and in most cases, any patient with an amputation, within 8 to 10 years after that amputation, they are dead. They do die, and it's not necessarily a complication from the surgery or from the amputation itself, but they become more dependent on their community. They become a burden on their families and friends, and that reduction in quality of life ultimately leads to a reduction in life expectancy. And those are the conversations that we should be having way before the patient starts losing sensation in their feet. That should be a conversation where even when those patients hit their pre-diabetic phase, their insulin resistance, if you don't start making lifestyle changes, you run a serious risk of losing a limb and losing your life. As podiatrists, we have our motto of save a limb, save a life. That is very true, and that's something we definitely need to reiterate with our patients. And going forward, what do we definitely need to drive is the tablet is there to help you. It's not there to cure you. The cure for you comes from lifestyle changes, making sure you exercise 3 to 4 times a week, making sure that at the braai, you choose a start. You're either going to go for potato bake or you're going to go for the braai breaker, but we can't have both. And that salad isn't decorative. It needs to be on the plate at some point. And then and having those discussions. And of course, working within a multidisciplinary team of endocrinologists, GPs, nurses, podiatrists, dietitians, biokineticists, and physios, working together that at every point of contact, that message gets across to patients. And that's one thing that as podiatrists we find often where we help within that team quite nicely is the patient's going to come and see me once every 6 to 8 weeks for a nail cutting. At that junction, I should, as a podiatrist, be asking, how's your sugar levels been? How's your cholesterol been? How's your hypertension been? Why are we having a spike? Why does it look like your feet haven't had attention since the last time I saw you? Have you been applying your creams? What's happening? What's going on? And often those patients go, no, look, been a bit stressed. I've been cheating a little bit. My sugar's been a bit high. And at that point of contact, we're bringing them back and reminding them again that we understand we're stressed, we're anxious, we want to eat, but we need to remember that this is a lifestyle disease. This is something that you're going to carry with you your whole life. You need to be constantly aware of it. You should be taking your meds, or if you're feeling that you're not responding to your meds, why don't you go see your endocrinologist or your GP sooner? Chat to them about the fact that you feel your meds might not be working as efficiently or as effectively as they have in the past. Because what I'm seeing for me is sending up red flags. I always tell my patients when it comes to diabetes, your foot is a ticking time bomb. At some point, you are going to have a diabetic foot complication. When it happens is up to you. And that needs to be the message that goes out to those patients regularly at every point of contact.
I'm sure you're making many dietitians very happy with what you just said, because it seems more a healthy eating kind of discussion, but it's actually so true. I mean, I think I'll be probably the first one to admit that, most people actually do start at the GPs, me being, one of the, previously anyway, now I'm a bit better, but it's so easy. You need to, sleep well, you need to eat well, you need to exercise, don't drink too much, don't smoke too much, or maybe don't smoke at all. And then you should be good, with a decent life. But I'm so glad that you, and I think Shaz started this, but you painted the grim picture, which I think most people need, because the grim picture always comes when you don't expect it. And I think if you start out with that and you're much more conscious in your life and you say, actually, I don't care, I just want to do it, and if it comes to the amputation, then it's cool. But I think it's sad when people don't expect it, and then it does happen, which I'm sure is, probably 99% of the time, that people don't say, actually, I don't really care, I'm just going to go and do it. But most people just kind of end up with that. And I think that's the biggest thing about doing something like this type of content and this type of show, is that we do want to paint it out to, the normal person that would want to look at diabetes and say, okay, what would be the best care that I could possibly get right now. And you said so many insightful things there that I didn't want to interrupt, but the key things was the lifestyle which you mentioned, the fact that you do have to choose and be much more conscious of it from a holistic health point of view, which is a big driver on the from a show point of view. The other thing which you mentioned, which was critical, is a multidisciplinary approach, and we've always, we see it with kids. And I think as adults, it took me a long time to realize this as well. Spending a lot of time, behind the computer, my posture is not great. So you do have to go see like a physio, a chiro, and all of those kind of things. But it's just almost to keep you doing what you're supposed to be doing. And the analogy that I use is like, if you look at the sports players, Federer, Nadal, Djokovic, they all have a team around them. But for some reason, we as the most important people in our own lives, we realize actually we can do this ourselves. Like we'll just somewhere, figure it out. And we don't really take that same approach, which is, you do need this team of specialists to keep you being the best that you can. And do you have any thoughts on that? Do you find many people actually do that?
So I'm quite fortunate in the environment in which I work, in that most patients do see us within our team holistically. They'll see me once every 8 weeks or so. They'll see the chiro and the bio on a regular basis. But it is definitely something, because the idea behind that is, or the perception behind it is, that it's very expensive to live that way. Yes, initially it might be. As you work with your team, as you select your team of healthcare professionals, you do develop a routine. All right. So I know that I struggle with my lower back pain. I should be seeing my chiro once a month, once every 6 weeks. I should be seeing my biokineticist at least once a month, look at my homework, look at my posture, help me with my desk setup, that sort of thing. I should be seeing my massage therapist or my physio once a month at least, to help everything loose. I should be seeing my podiatrist when I want to buy new shoes, or if I feel something happening with my heels, whatever. But it's definitely it is something. It's not what is expensive is when you have an acute injury, or you've injured yourself and now you need everyone's help at once. That's when it gets pricey. But selecting a team and having a team that can communicate well with one another to discuss, all right, where is patient X within our treatment protocol, within our treatment program of their condition, then it becomes a routine thing. It becomes like cutting your hair, and it should actually be that. I do think from the healthcare perspective side is we still, and COVID definitely has made it very apparent that we still operate in silos. I want to hold on to these patients as best as I can for as long as I can. I want to milk their medical aid for all that it's worth, because I need to get paid and I'm not seeing enough patients, and I'm going to, or you can go, I'm going to fix them. I don't need a chiro, I don't need a physio, I'm going to fix them. But at the end of the day, that patient doesn't respond. Whereas if within a multidisciplinary setting, you get a lot more brain power out of that. You have soundboards that you can bounce ideas off of. You have people with expertise that might not be within your scope, or might not be within your field of interest. And So that might be something that you can at least say, I'm dealing with this patient. I'm really not sure what I'm helping with. Please come and have a quick look, or please can I get your opinion on the matter? And as healthcare professionals, that's very important to communicate with each other, but also to communicate that with the patient of, I'm not 100% sure that what I'm going to do for you is going to help you. I do think you need a podiatrist, or you need someone else who's more experienced in this field, who will probably be able to give you better advice. And but that's also, it's a two-way street, unfortunately, of patients and practitioners walking that road and making that call together. And it is, like I said, just as what we've seen in podiatry, with there being a big awareness move, a mind shift or awareness shift as to the role of a podiatrist within the healthcare team, there's definitely been a big shift socially as well, with regards to holistic management or holistic health. Lots of patients are coming in, and that's one thing we need to remember. Patients are very well informed these days when it comes to their management and that sort of thing. So, and the holistic management is definitely a big thing in healthcare at the moment. And so it's very common now to find that patients will often sit with 2 or 3 practitioners at a time in a session to discuss what needs to happen with them. So yes, people are making that shift. It's very slowly, and we often, but we need to get out of that misconception of it being very expensive first. It is expensive when you have that injury, and you need to get the physio and the podiatrist and the sports physician involved to try and fix you. But once you've actually gotten into a good routine with everyone, and you might see that you might just need to see one of them once every few months, or all 3 of them once every few months. And that's where, and when you get to a point where the chiro feels that they can no longer assist you well, that they send you to the podiatrist because you either need orthotics, or you need a new shoe, or that sort of thing, or letting go of that patient once they're pain-free and sending them off to the biokineticist to do some strength training, look at their posture, and help rehab them appropriately, and help prevent those injuries later in life. And then if there's a new injury that comes in, we start all over again, and we move through the process. So, and I know, Oliver, we've chatted before, where you've said that I'm a very process-driven person. So I often do chat to patients about the processes that need to happen. And I do think that's definitely something that we as healthcare professionals need to drive. We need to get out of our silos, and we need to get more involved in the web and into our network more, with our colleagues, of varying expertise, various years of experience, various levels of interest, and learn from each other as healthcare professionals. Something that COVID has helped us with is webinars and that sort of thing. And now we're getting a lot more involved with webinars. So there is some form of learning, but however, we have lost that interaction to actually come up to each other and say, look, this is my case. Can we have a quick chat about it? And the same with patients these days. I know a lot of them are scared. They don't want to see multiple physicians at once, because of the risks involved. It definitely is something that if you want to get better and you want to stay on top of your game, you need a holistic approach. You can't, unfortunately, restore a Ferrari with just a hammer. That's the thing you need to remember.
I don't think I've heard that before. That is actually amazing. It's definitely one of those ones I'm going to remember. You know what you said now, and I think the worst case scenario is like you end up with an acute scenario, a condition, right? But I think what everyone talks about holistic at the moment, but almost like, go back to the Roger Federer example. It's almost like you need to be the best version or the best performing version of yourself right now. And then that doesn't look that expensive. Because if that's the objective, then the regular checkups with the podiatrist actually makes a lot of sense, because it's actually cheaper than ending up with the acute condition. And I think that's the mindset, people, one is the eating right and the holistic part. But I think there's almost like, and we buy these expensive cars and they tell you, this is your maintenance plan. But, we have like the most expensive thing around us, which is ourselves. And
Yes.
yet we don't actually have a maintenance plan that we have to go through.
Yes.
And
Yes.
which is interesting, hey? How people kind of go through that. And I think if people knew, and you mentioned that people are a lot more aware right now. And I think that's also the reason for something like this, that if someone is saying, okay, I just got diagnosed with diabetes, what does that mean for me? Can I see something from a podiatrist view? Okay, cool. I'll listen to this thing, and like Lucas was talking about that, and then you get a view from a dietitian, and then you get a view from a GP, and I think that's the approach that probably people are missing right now. It's like that more informed scenario. Whereas you just go to Google and you're going to search for a few things and you're not really sure. And what I'm hoping with this as well is someone says, actually, I really like what that practitioner said, and I want to make a booking because I think that that quite resonates with me. Is I can make time to go see him, once every 6 weeks or 8 weeks. That makes sense. And if we get to that stage, I think it will be amazing. And I think practitioners then also, if you have a lot more people proactive about their health, I don't think they're going to struggle for clients because you could have less acute and more maintenance. And as I firmly believe there's enough, clients, to be able to deal with that, or to keep practitioners really busy.
Yeah, you're going to have less difficult cases, and you're going to have less frustrated patients as well, than just having to deal with, when it's at its worst. Now you have 8 weeks to fix it. Whereas if you have a lot more healthier people, proactive people, as you said, it actually does work out a lot cheaper in the long run than waiting until it gets to the point where you have a hole in your foot, and that's going to cost you. And that's going to cost you it's going to cost you a couple of grand each session for months to try and get that wound healed. If not, then after that, and it failing, and you telling the patient, well, you're probably going to need surgery now, and then the thousands and then the hundreds of thousands that involves. So that's 100% correct. It does in the long run, but getting that message across and getting people to understand that is a bit of a challenge. It is definitely something. There is been a massive shift in the way people are thinking, which for the better. People are definitely a lot more aware of what they should be doing with their health, the type of teams they should be having behind them, and that awareness is still in its infancy, and we definitely, as healthcare practitioners, need to keep that momentum going, which is why we need to move out of those silos, and we need to move into our communities again and into our networks again to build those sort of teams that can keep the patient going without costing them an arm and a leg, if you'd excuse the pun.
Lucas, I think you just hit the nail on the head there. It's about actually getting back into our communities. It's getting out of our silos and going out and making sure that our communities and the other professionals around us know who you are, know what you do, and start to be able to know that, I have a patient with this issue and I need to make sure that I know where to send them to. But I think more than anything, from a human nature perspective, what we have definitely seen is that shift when it comes to mental health. And my hope will be is that shift starts to come with other aspects as well. You want to look after your mind 100%, but you also need to look after things like your feet, because as you say, you lose a foot, that changes your work situation. That puts you now needing occupational therapists, et cetera, et cetera. But if you maintain it and you listen to what your team is telling you, you stave that off for a lot longer. And I think that's the message we need to be getting out to people is it's going to cost you a lot less to do this on a regular basis than it is in the long run. And this is what the worst case scenario could be, which is what they did with mental health for a long time.
Yes.
You hold it in until such stage as you crack and you go and shoot someone. That's prison. Whereas you go and speak to someone on a regular basis, there's no prison.
Yes. Yeah. No, that's exactly it, and it's definitely happening with holistic health. And I mean, just if we can divert a little bit to, the amount of people that I see on a daily basis that go, I just don't, my self-image is affected because of the way my feet look. I mean, we've seen patients, especially diabetics, who've had amputations or who have active ulcers. I mean, those wounds, they are a burden on the family. They smell, the patient's unhappy, their family's unhappy, they become a burden on everyone. They get moved between families and that sort of thing, which isn't great for them either, or for the patient either. So, and we need to remember that, and even though we've had fantastic advances in mental health, we've lost that balance again between our mental and physical health, and how important those two are in regards. I mean, in the case of a diabetic patient, you'll often find someone being diagnosed with diabetes who will have some kind of emotional trauma in their past that has manifested in a physical way, if you want to put it that way. And so they need the help of their mental health practitioners, also of their physical health practitioners, or of their rehab practitioners, or of their physicians and that sort of thing. And getting that link going. And that's why it's so important, like what I said earlier. You see that patient once every 6 weeks, very important. How's it going? You know, what's happening in this period of time? So that if there is a red flag, you can address it at that point and tell the patient, look, we've talked, and our chats are lovely, but there's a red flag here, and maybe we should be getting someone else involved at this point, because I don't want you to, because you're feeling this way, end up hurting yourself or hurting your foot, and then becoming a burden on everyone else. Already stressed and that sort of thing. So how can we, and even though you might just be a podiatrist, in that situation, that being able to interact with that patient and identify certain things to get them back on track faster. And this is something that we might miss if we are thinking in a silo. Whereas, if you have your network with you and a patient says something, but that something's resonating, then maybe I should get a colleague to check this out for me and take it a little bit further and see where it goes. And that's when that patient will probably phone you a month or two later and say, you know what, I've been to your colleague, we've picked up something, and you most likely saved my life. And that's it. And that, regardless of the kind of practitioner you are, or who you are, or the amount of money you make, that is the value of your profession. That's why you entered the field in the first place, and that is the biggest reward that you can get, from everything from, you've saved my foot, you've saved my limb, to you have most likely saved my life at this point. And that's when you as a practitioner know your value, and know what you can add to your community. And that is where we need to start heading. We need to start setting that goal. I think as healthcare practitioners, we don't need to move away from the setting of goals of getting that diary full, and rather get to the goal of advancing life, advancing quality of life. And when you do that and you set that as your goal, again, regardless of where you practice or who you are or what sort of patients you see, that is going to add passion into your day. That's going to add passion into your profession, and that's what's going to bring those patients to you at the end of the day.
Yeah, I mean, you said that so well, and I couldn't help but think, we started with like how, from a dietitian view, but what you said now again is pretty profound, from a mental point of view, what the impact of that is. And I think, and then you took it up, a few levels, and I can kind of understand, why your practice is as busy as it is as well. Is because I think, when you speak to clients like this, about having an holistic approach and also pointing them in the right direction, from that multidisciplinary approach, I can't see that not working. And I think, I think your clients are, quite, privileged to have someone like you on their team, because I mean, if you're providing that to them, that's amazing. And I think if you can support that with other practitioners, that's even more critical. But I like what you said about, the emotional aspects And this, we could easily spin this into another topic. What came out of these many episodes that we've done so far is that, practitioners have even suggested to us, maybe you should have more than one practitioner on the same episode and say, maybe from almost like a multidisciplinary approach, we can approach this topic of, diabetes management, so from a dietitian view, from a, from a GP view, all of those, and a podiatrist view, obviously, as well. So that's quite interesting. What do you think of something like that? It's obviously going to be fairly new, but something like that, do you think would have some merit?
That would be brilliant. But if you're going to get everyone involved on that, you're going to need. You're gonna need lunch. It's definitely going to be something that is quite a nice topic to chat about. But those discussions get lengthy. So but it would be brilliant to have this sort of discussion in a multidisciplinary setting, and bouncing off. Like I said, very important to soundboard with colleagues and bounce ideas off one another. And just get people's thoughts and perceptions, just to generate some more awareness. But yes, if they're anything like me, I know. I mean, you're going to need a day to get them just to get through a few questions.
Yeah, but I think it would be amazing. And again, let's put ourselves in the mindset of the person looking for assistance, and to be able to have like multiple views in the same session, which would be amazing. It goes with what you were saying saying all along in this episode about having a holistic view, and not just thinking about it from an acute condition, but more as a maintenance, and just taking care of the patient in the best way. And I think you already said this as well. Patients are already looking. And, hopefully when they see, actually, I do know that practitioner, and he's just down the road from us, or, he's in Pretoria, and, I want to, I don't want someone's opinion from New Zealand or Australia. I want someone that knows South African conditions, the fact, and that's why I don't want to wear closed shoes, and stuff like that. I think there's definitely value there. But I think, so the one thing, it's funny how the mind works, but I can't go away from this one. You mentioned with amputees, and it's still been in my mind there, but why does the life expectancy decrease? Is it just, is it something medical, or is it more just emotional?
In
your opinion?
So you do have the medical side of it, where it is incredibly taxing on the body to recover from something as traumatic as an amputation. And there are a whole host of complications, infections. You can have recurring wounds as a result of on the amputation site itself that may require second amputations or revision surgeries or that sort of thing. And then you have the impact that it has on the patient's quality of life. If we take an example of these sort of patients in a state setting, it takes them months to get onto a list for the amputation. It takes months for them to get onto a rehab program. It gets months for them to get their prosthesis going, or sometimes there aren't materials for their prosthesis, and then it takes years before they get something. And the emotional burden that places on them, because they are aware now they have to become more dependent on family members, on their kids, they financially as well as time, because they need to be taken to appointments and that sort of thing. And that all of that does play a role in reducing their life expectancy significantly. So again, it's a big combination. It's not just the emotional side, although I do believe it is most likely one of the most traumatic things a person could go through. But it's also the physiological side, the amount of stress and trauma you go through physiologically, trying to recover from something as like an amputation is extremely taxing on the body. And then, of course, you'll probably always have some kind of complication where there is a phantom limb pain, recurring ulceration from a prosthesis or from a wound that's not healing well, that sort of thing, and that again, might require revision surgeries and that sort of thing before it gets 100%. It's definitely a culmination of both psychological and physiological trauma that results in that reduction in life expectancy. And I think mainly because of the significant impact it has on a patient's quality of life.
Lucas, I think you just hit the nail on the head there. And I think that's what often happens with diabetic patients is you've got the physical side of I have diabetes and I need to manage this with eating right and so on. But then you also have that mental side, that emotional side that plays a very big role. And I think what Oliver was saying earlier would be really great is to have some sort of conversation where we actually cover all those from a dietitian and everyone across, because I think there's so much knowledge out there about diabetes, but I don't think that the common person has enough knowledge or understanding that this isn't an illness that can be treated by one person. There are so many different sides that you need to take into consideration. And, if you're looking after A and you neglect B, you're going to wind up in the same situation. I think that's the biggest point to get across with anybody with diabetes is it's not just about taking the insulin. It's not just about taking the pill. It is about changing that lifestyle. It is about the regular care and maintenance. And, if you're not doing that, that grim picture becomes a lot clearer, a lot faster.
Yeah, that's exactly it. That's 100% correct. And that's why we need to, from the beginning, have very frank discussions with our patient when it comes to diabetes and the complications of diabetes, especially when it comes to things like the diabetic foot, which is possibly the one aspect that I think every healthcare practitioner can agree on. It is a very sad and very scary thing to observe in a patient from the beginning, having acute severe pain to them not feeling anything, and then ultimately when worse comes to worse, having a foot that comes off. So that is definitely, and especially with diseases such as diabetes. It's well researched, it's well publicized. We know there's a big driving force in education behind it. Yet South Africa still sits with one of the highest figures when it comes to type 2 or non-insulin dependent diabetes. And why is that? Is it just because where's the gap happening? Is it because we are just trying to push patients through and we're not educating our patients enough? We're not making them aware enough? Is it an attitude thing that we need to consider? Is it because we as South Africans have that attitude of the doctor's going to fix me, he's going to give me a pill, he's going to give me a shot, and I'm going to be fine? Or the thing is, there's actually always a denial thing. I don't really have diabetes. They're making it up. That sort of thing. And it's definitely aspects that we as healthcare practitioners need to find out, because we know there are plenty of resources out there, but why are we not utilizing? Why is society not utilizing it as efficiently as we would like it to be utilized, or as efficiently as we know it can be utilized, from what we've seen with other programs internationally and that sort of thing?
Yeah, I mean, this has been amazing, to the point where, it's going to be a resource that I actually put my wife to, in terms of her own mom, because I don't think we've had that conversation as yet. So I've never seen it come up, but, you've mentioned some really, really good points. And I think, we've not just talked, we've done really good justice on the topic of, food management for diabetics, but is there anything that you can think of that we should have asked you that we didn't around this topic?
I think we've covered it quite well. I don't think we need to go into any more detail, but what I definitely would like to highlight with this is when it comes to your foot, you need a podiatrist involvement at some point. When it comes to having as part of your management plan of diabetes, your feet need to take priority there. Just as important as it is to maintain your sugar levels, if you want to be an active part of your family, of your community, you need to have a firm foundation that comes from your feet. And it should, and I really want to urge every single colleague who's listening that we need to get out of those silos. We need to start looking at holistic care for our patients. And I'm not talking holistic as in 50% homeopathy, 50% allopathy. But I'm talking about us working together, sharing information, not being scared that by telling a patient, I don't know what's growing on your foot, that you're going to lose that patient forever. You might likely save that patient a lot of pain, a lot of frustration, and yourself a lot of sleepless nights by being involved with your colleagues and with your patients as well. And if COVID has taught us anything, is that we should be going back to that way of practicing medicine. The isolating a patient and trying, hitting our heads 1,000 times before we get to the point where you're angry, the patient's angry, you just want to get rid of one another. That before it gets to that point, getting other practitioners involved, getting the community involved. The most profound eureka moments happen when you're sitting in a conversation with a colleague or with a friend over a cup of coffee, discussing something that you might not be sure of, or just that you need to get off your chest. And that's where we need to start heading in healthcare, especially post-COVID, para-COVID. But if we want to get through it, we need to start leaning on each other more.
Yeah, well said. I mean, I think that's amazing, and I'm glad you brought the other practitioner aspects to it as well. Because there's such a movement with children again. Because our kids, we've been busy with them in terms of practitioners and all of that stuff, and there's such a movement around early intervention. And almost, what you're saying there as well is, it's that early intervention. When something is presenting, maybe put up your hand and say, like you just said now. I'm not quite sure, but these should be my circle of reference. Maybe let's speak to them. It doesn't even have to be, obviously with the patient's consent and stuff like that. Say, can I take this to my colleagues? To just double check if I'm on the right track with this. And I can't see many patients saying, actually, no, I don't think so, because it's in their best interest to do that.
Yes, and that's definitely. We always stay with prevention is better than cure. That is always the truest of the truths out there. And the earlier you get it seen to, the earlier you get involved, the earlier you get your team involved in managing a patient, the earlier you number one, your results are phenomenal. And the time span in which those results occur is also phenomenal. So it's definitely something worth investing in, and investing in yourself and in your practice.
Yeah, again, it's really nicely said. Shez, we want to close it up now. Is there anything on your side that we should have asked Lucas that we should have that we didn't?
No, I think we've covered the topic really, really well. And I think we actually got a lot more out of the discussion than we had anticipated, especially with Lucas's passion across what is there.
Sorry. You were saying?
No, I was just saying it's that absolute passion that carries through. I think anybody listening to Lucas talking about feet understands that this is important to him because it's important to humans as you go along. You said it right. There's no foundation if you don't have feet.
Or they're just going to think he has a really, really hectic foot fetish.
Yeah, I know. And maybe we should, because essentially, I mean, like, the hands and the feet, I mean, again, I mean, like, I've been to reflexology before, and, they say there's so many, like, pressure points within the feet that actually, there's so much of value there. That I think, I just have to ask the question. I mean, are there enough podiatrists in South Africa to be able to cater for maybe the demand if the floodgates do open?
No. Podiatry is actually a scarce skill in South Africa, and it is most likely due to the fact that we only have one training institution that can actually produce podiatrists from a South African perspective, and we tend to lose a lot of colleagues to international markets. We lose a lot of colleagues who immigrate to pursue podiatry in other countries, which is quite sad. And there's I have a lot of personal opinions about it, but yes, that's one of the biggest reasons why. The other issue is we don't necessarily have public posts, so very few. So most podiatrists in the public sector are at a tertiary level, so within a tier 3 or tier 4 hospital, which means they're not on a grassroots level interacting with patients at a primary healthcare level, and that is often that's the sad case, and that's why we're not as visible also, because we're not necessarily regarded as primary healthcare practitioners or on a grassroots level. And in order to make that big impact and to have that visibility, you need to be at a grassroots level to make that sort of change.
Yeah, I mean, and that's been my experience as well. I mean, like, obviously we started many years ago, with, working with healthcare practitioners. And I mean, podiatry wasn't, or podiatrists weren't even, list at any point, and we kind of just stumbled onto it. But it's actually interesting, what you mentioned. But let's leave it there. Shaz said it really well. I mean, your passion shows through. I mean, we'll have your contact details in the notes. And I think for anyone listening to this, I mean, I'm sure they're going to have lots of questions around it, or going to be reaching out and say, I actually liked what Lucas said. So thanks very much for giving us the opportunity to have you on the show and to talk about this, because I think it's a critical topic. And more importantly, I think it's critical in terms of the work that podiatrists do. And I think, yes, we covered one aspect of it, and I think we could have many, many other topics, and Shaz actually highlighted another one. But, and then hopefully have you on again, talking about another topic around this. But yes. Thanks again.
Yes. Thank you very much for having me. It's been awesome chatting to you guys.
Thanks very much, Lucas.
All righty.
Hey, everyone. Thanks for listening. As always, stay tuned, and we'll speak to you in the next episode.